Do not trust symptoms. These are the clues that a liver is carrying fat after 60, and the first clue is that you may feel perfectly normal. You can spend months watching tiredness or a vague ache while the useful evidence sits in an ordinary lab folder. That is not a motivation problem. It is an assembly problem. A clinical care pathway estimates that this condition affects roughly 37% of adults in the United States, yet it is largely silent. Paying attention to your body is still wise, but waiting for your body to name this condition can waste the best chance to find it calmly. Picture a yellow rectangle stuck across the front of your lab folder. It has a blank line, a date box, and a place for one word. Before this video ends, I will show you the word, the exact blood test cutoffs, and the weight loss thresholds that changed real liver tissue in human studies. The myth is that fatty liver announces itself through a neat symptom checklist. The evidence says the root problem is almost the opposite. Most people notice nothing. A minority report fatigue or a dull ache beneath the ribs on the right side. Both feelings have many possible causes, so neither can tell you that your liver carries fat. They are reasons to ask, not reasons to diagnose yourself. Fatty liver is often found by accident through elevated liver enzymes or imaging. That means the honest clues come in two layers. Your body may offer a soft hint. Testing builds the picture. Miss that distinction, and the door can close before the useful questions are asked. The feeling is real. The meaning is still open. The proper name used in these studies is non-alcoholic fatty liver disease. It means fat has accumulated in the liver in a pattern not explained by alcohol. The invisible mechanism that matters most is fibrosis risk. Fibrosis is scar tissue that can build as liver injury progresses. Fat and fibrosis are related, but they are not the same finding. One can be seen on imaging, while the other needs careful staging. That yellow rectangle is your checkup window. It begins when the relevant information is available and closes when the next clinical decision is made. 5 ordinary habits can intercept it. They can leave a useful clue sitting alone until the appointment ends. I will give you the full 5-part sequence, with the FIB4 cutoffs under 1.3 and at least 2.67 before this video ends. First, you need to see how the window gets lost. The evidence comes from a deliberate mix. A clinical care pathway explains why screening matters. Human reviews describe what people notice and how body fat distribution reaches the liver. A prospective screening study shows what happens when tests meet an unselected population. Individual patient data and other meta-analyses compare thousands of people across studies. A biopsy study shows how liver tissue changed during 52 weeks of lifestyle modification. Each source answers a different question. None can answer every question. I will keep those evidence types inside the claims they support, so a group result never becomes a promise about your body. Vigiceptor 1 is the most praised habit of all. You listen to your body. That is good. But you also wait for a clear warning before mentioning the liver. The timing is costly, because this condition is usually quiet. A human review reported that most patients had no symptoms, although some had fatigue or pain in the right upper part of the abdomen. The same review said fatty liver was commonly discovered by accident when liver enzymes were elevated or fat appeared on imaging. So keep listening to your body, but do not make a loud symptom the price of asking a quiet question. The attention was real. The map was wrong. Tomorrow, the better move is simple. If fatigue or a right-sided dull ache concerns you, treat it as a prompt for a conversation, not as proof of liver disease. The Kinza 4-please enzyme Adscoverfavis weld in Thingal Cephei. An enzyme is flagged on a report, so every bit of attention goes to that one line. Looking at a flagged result is sensible, but one isolated value cannot perform the job of a staged risk assessment. The FIB4 index combines age, platelet count, ALT, and AST. ALT and AST are liver enzymes. Platelets are blood cells that help clotting. A meta-analysis using individual data from 37 studies and 5,735 people found that FIB4 had an area under the curve of 0.76 for advanced fibrosis. That measure describes how well a test separates higher risk from lower risk across a group. It does not diagnose one person. The useful unit is the combination, not the lonely red mark. Keep the report. Change how you read it. I nearly made that exact mistake while sorting the evidence for this episode. I opened an old-style lab page, and my eye jumped straight to ALT and AST, because those names looked like the liver. The platelet count felt unrelated, and age felt too obvious to matter. I had the information in front of me, but I had not assembled its meaning. Someone can do everything they were told, keep every report, attend every visit, and still miss the score hiding across separate lines. That person is not careless. The page was organized by test, while the clinical question lives across tests. Hold that thought, because one of the 5 letters on the yellow rectangle exists only to correct this mistake. Vax% of the Sommerkinders. Vax% of the Sommerkinders. Interceptor 3 is the bathroom scale. You see a familiar weight or a body mass index below the obesity range, so fatty liver feels unlikely. Tracking weight can be useful, but the liver responds to where fat is stored, not only to total body size. A human review reported that fat distribution played a greater role in insulin resistance than body mass index. It described free fatty acids from visceral fat, the fat around the organs, entering the portal vein. The portal vein is the route carrying blood from the digestive organs toward the liver. That review also identified excess free fatty acids and low-grade inflammation as important contributors to liver injury progressing. The scale reports mass. It does not show the route. Keep the scale if it helps you. Just do not ask it to clear your liver. You have to mudesin, udematua. You hear that a biopsy can determine inflammation, so you assume every honest liver assessment ends there. Avoiding an unnecessary invasive procedure is reasonable, but the pathway can begin with ordinary blood tests and move in stages. In the large diagnostic meta-analysis, a sequential process used FIB4 first and liver stiffness measurement second. With the studied cutoffs, sensitivity was 66% and specificity was 86%. Sensitivity describes how often the process caught advanced fibrosis among people who had it. Specificity describes how often it correctly reassured people who did not. Only 33% still needed a biopsy in that analysis. The needle is not the first door. Staged testing is the hallway before it. Generation Interceptor 5 is the perfect target. You hear that liver health improves with weight loss, so you wait until a large result feels possible. Wanting a meaningful change makes sense, but the evidence does not show a switch that stays off until a heroic number appears. A systematic review and meta-analysis covered 43 studies and 2,809 participants. Every 1 kilogram of body weight lost was associated with a 0.83 unit per liter reduction in ALT, a 0.56 unit per liter reduction in AST, and a 0.77 percentage point reduction in liver fat measured by imaging or tissue. The relationship had a dose response for several liver outcomes, although the evidence was limited for fibrosis itself. Small progress was not empty progress. Waiting for perfect can intercept useful change. Now the first loop closes. Those 5 interceptors are symptom waiting, the lonely red number, the scale as a liver test, fear of a biopsy, and the belief that only large weight loss counts. None begins as a foolish idea. Each begins with a sensible instinct placed in the wrong job. A symptom can start a conversation. A lab value can draw attention. A scale can track mass. Concern about a procedure can produce good questions. A larger goal can offer direction. But each becomes costly when it blocks the next layer of evidence. The problem is not effort. The appointment can end before the clues are assembled. That is why the yellow rectangle has an expiration line. The appointment ends before the clues are assembled. That sentence is the spine of the entire episode. It explains why noticing more symptoms cannot solve the problem by itself. It also explains why one laboratory value, one body weight, or one frightening word cannot finish the assessment. The useful act is connection. A clue has to reach the next clue before the clinical decision closes. What does this window look like in real life? The morning of an ordinary appointment starts the cascade. A lab report may already exist. A new blood draw may be ordered. The portal may post results. The visit may focus on the loudest problem. A single enzyme may be discussed, or normal-looking body weight may offer false comfort. The window remains open, while the evidence can still be connected to a next step. It closes when the clinical decision is made without that connection. No biology suddenly changes at the office door. The missed opportunity is practical. The pieces were available, but nobody put them in sequence. Before that window closes, the useful questions are whether liver fat has been seen, whether fibrosis risk has been estimated, and what test should come next if the first score is unclear. Why focus on the liver this way? Because access is uneven. Fat may appear on imaging, inflammation may require closer evaluation, and fibrosis risk may be estimated from values collected for other reasons. The liver also sits directly downstream from visceral fat through the portal circulation. That does not mean every person with fat around the middle has fatty liver. It means body shape and body mass cannot settle the question. After 60, one detail becomes especially easy to overlook. Age is itself one of the inputs in FIB4, beside platelets, ALT, and AST. A score that uses age cannot be understood by staring at enzymes alone. The narrowing window is not a mysterious morning hormone. It is the short interval in which scattered information can become a clinical decision. That distinction protects you from two opposite errors. One is false reassurance, because a familiar number looks comfortable. The other is panic, because a single result is outside a printed range. A combined score does not remove judgment. It gives the judgment a more relevant starting point. The goal is neither the fewest tests nor the most tests. The goal is the next test that answers the question left open by the last one. That is what staging means in practice. The old framework deserves a fair defense. Symptom checklists help people describe what they feel. Body mass index helps describe weight relative to height. A flagged enzyme tells a clinician where to look. None of those tools is dishonest. The failure comes when a tool built for one population or one task is asked to answer a different question. Fatty liver is largely silent, so a symptom list cannot serve as a screening system. Body mass index does not reveal fat distribution. One enzyme does not equal a fibrosis score. The missing variable is sequence. You were given several useful pieces, but not the order that turns them into a risk discussion. That can feel unfair when a neighbor with the same weight gets a different scan result. Biology did not reward one person and punish the other. The scale simply hid where the fat was stored. The word on the yellow rectangle is score. S means symptoms start questions. C means combine the ordinary lab values. O means organ fat outranks a scale assumption. R means risk is staged, not guessed. E means every kilogram matters. Before your next clinical decision closes, those 5 letters move from what you notice to what the evidence can actually support. I delayed the word because an acronym without the interceptors would become another checklist. You would remember the letters, but miss why their order matters. SCORE is not a home diagnosis. It is a conversation sequence. It tells you which clue opens the door, which measurements belong together, and where a clinician decides whether another test is appropriate. One objection could end this entire idea. If the condition is silent, should every person simply assume they need every test? No, feeling worried is not evidence of fibrosis, and more testing is not automatically better care. A prospective human study screened 3,378 people, including 1,973 from the general population and groups at risk from alcohol-related liver disease or fatty liver. Among the general population, 3.4% screened positive, but the common scores also produced false alarms. The ELF test had 11% false positives, compared with 35% for FIB4 and 45% for the NAFLD fibrosis score, while false negatives stayed below 8%. A positive screen is not a verdict. It is a reason for the next stage. The study also showed why a single cutoff cannot carry the whole burden. False positives deserve plain language. They are results that flag risk in people who do not prove to have the condition being screened for. False negatives are the reverse. They can miss risk that is present. A test can reduce one error while allowing more of the other, which is why the next stage matters. You do not need to choose between blind trust and total distrust. You need to know what job the test was designed to do. That prospective study offers a useful dose of humility. Of 155 people who screened positive and then had a biopsy, 54, or 35%, had advanced fibrosis. A screening tool is designed to sort risk, not to write a final diagnosis. So the answer to uncertainty is not to ignore the score. It is to place the score in a sequence. The first test narrows the group. A second test can narrow it further. A clinician decides who still needs a biopsy. Not through symptoms alone, not through the scale alone, not through one red number. The root is assembled evidence. The dread comes from imagining a hidden disease. Relief comes from seeing that the first steps can be ordinary and non-invasive. Stamp 1. Before the blood is interpreted. The available inputs are age, platelet count, ALT, and AST. These are not 4 diagnoses. They are 4 parts used in FIB4. The free high-value action is to know whether those values exist on a clinician-ordered report and to ask whether they are appropriate for calculating the score. Do not change medication, skip food, or arrange your own testing from this video. Follow the instructions from the clinic that orders the blood work. The convergent state is simple. The pieces sit in one clinical view instead of 4 unrelated rows. The window closes when a decision is made from one value alone. 4 inputs, 1 question. Tomorrow, you can locate the report without interpreting it yourself. Stamp 2. The first risk sort. The diagnostic meta-analysis studied FIB4 cutoffs under 1.3 and at least 2.67. A result below the lower cutoff and a result above the higher cutoff lead to different risk pathways in the studied sequence. The space between them is not failure. It is the reason staged testing exists. FIB4 reached an area under the curve of 0.76 for advanced fibrosis, compared with 0.73 for the NAFLD fibrosis score. Those values describe performance across thousands of people. They do not turn your result into certainty. The convergent state is a risk category a clinician can interpret. The window closes when the score is treated as a diagnosis or ignored as meaningless. A score sorts, it does not sentence. Tomorrow, the useful question is what the result changes next. Stamp 3. Liver stiffness. Transient elastography is the liver stiffness measurement used in the diagnostic meta-analysis. It reached an area under the curve of 0.85 for advanced fibrosis, higher than the blood-based scores in that analysis. The name sounds technical, but the job is plain. It adds information about stiffness after the first risk sort. The convergent state is a narrower estimate of who may carry advanced fibrosis. The sequential combination had 66% sensitivity and 86% specificity, and 33% still needed a biopsy. That last number matters because the test does not erase uncertainty. It reduces unnecessary certainty in both directions. The window closes when someone jumps from a blood score to a final label. Stage first. Escalate only when appropriate. Tomorrow, ask what second stage follows an unclear first score. Stamp 4. The longer view. A score can help estimate what may be present now, but reviews also asked whether these markers predict later outcomes. A systematic review covered 13 studies, with follow-up lasting from 1 to 20 years. FIB4, the NAFLD fibrosis score, and APRI showed consistently good prediction of liver-related events, with areas under the curve from 0.69 to 0.92. For mortality, FIB4 and the NAFLD fibrosis score performed better than APRI in every included study. But all studies came from secondary or tertiary care, where patients are already more selected than the general population. The convergent state is context. A number means more when you know who was studied. The window closes when a population result is mistaken for a personal forecast. Prediction needs a setting. Tomorrow, ask what your score can and cannot predict. Stamp 5. The title's most useful provocation lands here. The strongest clue may be no symptom at all, and the most hopeful finding begins before dramatic weight loss. Every kilogram mattered in the meta-analysis. The liver markers moved in a favorable direction with each 1 kilogram lost, and measured liver fat fell by 0.77 percentage points on average. The behavior does not create a hidden liver switch. It gives an already responsive organ less metabolic pressure. This is the first score component you can use tomorrow. E means every kilogram matters. But it does not mean every person should chase weight loss without guidance. If medication, frailty, appetite loss, or another condition makes weight change complicated, it is worth asking your doctor before setting a target. Small progress counts. Unsupervised pressure does not. The yellow rectangle has now been stamped at 5 points. Body clue, combined blood values, fat distribution, staged risk, proportional change. This is where the mechanism becomes a system. The clue that feels most vivid is not always the clue that carries the most information. Fatigue feels personal, but it is non-specific. A FIB-4 score feels impersonal, but it combines 4 relevant inputs. A scale number feels precise, but it cannot locate fat. A biopsy sounds definitive, but most people in the staged diagnostic analysis did not go straight to 1. A large weight goal sounds serious, but the meta-analysis found measurable changes per kilogram. The arrangement changes the value of each piece. Same evidence, better sequence. One popular instruction can cancel this window. Lose weight first, and only worry about tests if that fails. The advice contains a sound idea because weight loss can improve liver outcomes, but placing it before risk staging asks progress to do the job of diagnosis. In a human study of 293 people with biopsy-proven steatohepatitis, followed for 52 weeks, weight loss was associated with improvement across liver tissue measures. Among people who lost at least 5% of body weight, 58% had resolution of steatohepatitis, compared with those who lost less than 5%. Among those who lost at least 10%, every participant reduced the activity score, 90% had resolution, and 45% had fibrosis regression. Those are powerful group results. They are not permission to postpone finding out where you stand. The stronger frame is test and improve, not improve and hope. You may spend real effort changing weight, while fibrosis risk remains unknown. That effort is not wasted. The order is incomplete. The 52-week study also showed why outcomes must be named precisely. Resolution of steatohepatitis is not the same as regression of fibrosis. At the 10% threshold, those results were 90% and 45%. One improved more often than the other. The larger meta-analysis likewise found limited evidence for a dose response between weight loss and fibrosis, even though several other outcomes improved. So weight loss can help without guaranteeing that scar tissue has reversed. The cost of skipping the risk step is not failed effort, it is unanswered risk. Before we keep going, take a guess in the comments. Which one do you think earns the top spot? The answer is not a dramatic symptom. It is the sequence that turns ordinary clues into the next appropriate decision. You now have the partial payoff. Every kilogram can matter, while the checkup window still needs staged evidence. Next comes the full score protocol, letter by letter. Each letter closes one interceptor. Each one ends with the sequence you have built so far. My own paper sort failed all 5 intercepts before I noticed the pattern. I looked for a feeling first. I stared at individual enzymes. I let the scale stand in for fat distribution. I treated biopsy as the unavoidable ending. I imagined that only a large weight result would be meaningful. The single change was not a new remedy. I changed the order of the questions. That shift turned a pile of facts into a route. I am not offering my folder as clinical proof. It is an illustration, of how an attentive person can still use the wrong sequence. If you have kept every appointment and still feel unsure, the uncertainty is not evidence that you failed. The clues need assembly. Order makes evidence useful. S means symptoms start questions. This closes interceptor 1, waiting for a clear warning. The rule is that fatigue or a dull ache under the right ribs may be mentioned, but neither may be promoted into a diagnosis. Most people with fatty liver are asymptomatic in the human review, and the condition is often found incidentally through enzymes or imaging. The flaw is noticing and recording a concern in plain language. The ideal is bringing that concern to a clinician who can consider other causes and decide whether liver testing fits. The ceiling is refusing to read a common symptom as proof. You may keep listening to your body. You may keep asking why a feeling changed. You simply remove the burden of diagnosis from the feeling. Score so far. Symptoms open the conversation. Quiet does not mean clear. C means combine the ordinary lab values. This closes interceptor 2, the lonely red number. The one-line rule is age plus platelet count plus ALT plus AST, interpreted by a clinician as FIB4. The flaw is finding out whether those values are present in clinician-ordered blood work. The ideal is asking whether the combined score is appropriate for your situation. The ceiling is not repeating tests, changing medicines, or calculating your way into a diagnosis without clinical context. The individual patient data meta-analysis found FIB4 at 0.76 for separating advanced fibrosis risk across the study group. It performed better than the NAFLD fibrosis score at 0.73, but below liver stiffness measurement at 0.85. You may keep paying attention to a flagged value. Just give it its teammates. Score so far. Symptoms open, combined labs sort. 4 rows become 1 question. O means organ fat outranks a scale assumption. This closes interceptor 3, using body weight as clearance. The rule is that mass and distribution answer different questions. The flaw is dropping the belief that a familiar weight rules fatty liver out. The ideal is letting a clinician connect body composition, metabolic health, imaging, and blood work as appropriate. The ceiling is not diagnosing liver fat from waist shape, mirror changes, or body mass index in either direction. The human review found that fat distribution mattered more than body mass index for insulin resistance, and described the portal route from visceral fat toward the liver. You may keep a scale for trends if it serves you. You just stop making it a liver scan. Score so far. Symptoms open, labs combine, organ risk escapes the scale, location changes the story. Bar means risk is staged, not guessed. This closes interceptor 4, assuming assessment begins with a biopsy. The rule is blood-based sorting first, liver stiffness next when indicated, and invasive confirmation only when the clinical pathway still requires it. The flaw is asking whether FIB4 applies. The ideal is having the cutoff interpreted and learning what second stage follows an unclear or higher result. The ceiling is treating under 1.3 as a lifetime guarantee, or at least 2.67 as a diagnosis. In the diagnostic meta-analysis, the sequence using those cutoffs and elastography still sent 33% toward biopsy. That is not a defect hidden in the fine print. It is evidence that staged testing narrows uncertainty rather than pretending to erase it. Score so far, symptoms open, labs combine, organ fat escapes the scale, risk moves in stages. Sort before you label. E means every kilogram matters. This closes interceptor 5, waiting for a perfect transformation. The rule is that improvement can begin with modest loss, while larger thresholds in one 52-week study were associated with larger tissue changes. The flaw supported by the meta-analysis is not a minimum target. It is the finding that each 1 kilogram lost was associated with measurable average improvement. The 5% threshold marked stronger resolution in the biopsy study. The 10% threshold marked still larger group results. Neither is a universal prescription or a ceiling. These facts do not justify an upper target, a deadline for you, or rapid loss. If you take medication, or manage a condition, a weight plan is worth asking your doctor about. Score complete, symptoms, combined labs, organ distribution, staged risk, every kilogram. 5 clues, 1 sequence. The exact numbers deserve 1 clean pass. Per 1 kilogram lost, the meta-analysis found average reductions of 0.83 units per liter in ALT, 0.56 units per liter in AST, and 0.77 percentage points in liver fat. At least 5% weight loss in the biopsy study was associated with 58% resolution of steatohepatitis, compared with less than 5%. At least 10% was associated with lower activity scores in every participant, 90% resolution, and 45% fibrosis regression. Those figures describe groups, not a promise to an individual. The safety line is equally exact. Do not stop medication or force weight loss to chase a threshold. Bring the target to your doctor, especially when medication, muscle loss, appetite, or another illness could change the trade-off. Progress should improve health, not merely shrink a number. After the payoff, one mistake can invalidate the whole sequence. It is treating a FIB4 result as the diagnosis. The fix fits in one sentence. Use it as a clinician-interpreted referral and staging trigger, never as a home verdict. A second mistake is less serious but still common. It is treating normal body weight as proof that fat cannot sit in the liver. The fix is to separate amount from location and ask what testing actually showed. A third caution belongs beside the weight findings. Improved enzymes and reduced liver fat do not prove that fibrosis changed at the same rate. The evidence for that dose response was limited in the larger meta-analysis. Better markers are encouraging. Scar risk still deserves its own answer. The paradox is that a silent condition asks you to become less obsessed with sensations and more precise about questions. That does not mean ignoring your body. It means refusing to make your body perform a test it cannot perform. The yellow rectangle expires when the visit ends without a next step, not because your liver suddenly changes, but because scattered evidence stays scattered. The word score keeps the sequence visible. Start with the symptom if there is one. Combine the lab values. Separate organ fat from a scale assumption. Stage risk through the proper pathway. Remember that each kilogram can matter. The checkup window is practical, and the next appointment can reopen it. You do not need a speech for that appointment. One calm sentence can carry the sequence. I understand this can be silent. So do my existing blood results say anything about fibrosis risk, and would another stage be appropriate? That is a question, not a demand for a diagnosis. It leaves room for your clinician to consider causes and context that this episode cannot see. If a scan already showed liver fat, say so. If fatigue or right-sided discomfort worries you, say that too. If weight has changed without you intending it, do not turn this evidence into a weight loss plan on your own. Bring the change to your doctor as part of the full picture. Let me put the lab folder away for a moment. If you have been waiting for a dramatic warning, you were not foolish. You were using the kind of signal that works for many other problems. I did the same thing when my eye chased the familiar enzyme names and skipped the structure around them. But fatty liver is largely silent, so the clues that a liver is carrying fat after 60 are not a symptom checklist. They are a soft body clue, an accidental finding, a combined blood score, stage testing, and a pattern of improvement that can begin with modest change. The effort was real. The order needed repair. Strip away the details, and one pattern stands out. Symptoms can start the question, but tests carry the answer. FIB4 combines age, platelets, ALT, and AST. The studied cutoffs were under 1.3 and at least 2.67, with liver stiffness measurement used as the next stage in the diagnostic sequence. Body mass index cannot show where fat sits. Weight change helped liver markers per kilogram, while 5% and 10% marked stronger outcomes in the 52-week biopsy study. 5 clues. 1 score sequence. The research links are all below, laid out study by study. My job is to explain the science clearly. Your clinician's job is to fit it to you. Both matter. This is education, not personal medical advice. You can find every study in the description, including the reviews, the screening study, the diagnostic meta-analysis, and the 52-week biopsy study. The next video answers a question I keep getting asked about what liver enzymes can and cannot tell you. That is where we separate a useful signal from a false all clear.